tape because there is going to be a point that you need to know how to tape. I'm also going to show you this. This is a Hollister. This is very commonly used at a lot of places. You would take the sticky off here. It goes above the lip, so it's like this, and then would go down and around. And then Velcro. I always thought it looked so simple to use, and then people were like, they had a Hollister and I had it on upside down and I turned it the wrong way, and I was like, okay, I'm gonna show everybody. Then this tab here, we're not gonna do this because then I can't show it, but it has a little tab right here, and what you do is put the tube underneath here and then put it in here, and then you would shut that, and that would hold it in place. One of the nice things about this, we need to move our tubes around. So if your tube is attached to this, this has what I say looks like a little zip tie thing on it. It just slides. So you can go to the right, to the middle, to the left, to the middle, to the right, over and over and over again, because that's how we move it. Right, middle, left. Wherever it starts, you're gonna go end up right, middle, left, middle, right, middle, left, back and forth, to prevent pressure sores. Yes.
What happens if you have a patient that's allergic to the adhesive?
Yeah, that's when you can't use it. This is not for everybody.
Okay.
Yes.
How often do you move it back?
Well, a lot of places do every 2 hours, every 4 hours, once a shift. So the minimum, no, the minimum required movement of a tube is at least once a shift. Or I should say every 8 hours. I don't want to say once a shift because that's every 12 hours. Yeah, every 8 hours. One of the new incentives out there is for pressure ulcers. RT modalities are at high risk to leave pressure ulcers on our patient. Nasal cannulas do them here. Trach tubes do it here. Endotracheal tubes do it here. BiPAP masks do it here. So that's 4 things that we are in charge of that can cause pressure ulcers on our patient. It's a very high risk. They get infected. They're very painful for the patient. And guess what? If somebody gets one, the insurance isn't paying for the care for it. So there's a heightened awareness of pressure ulcers now in the hospitals, and so moving the tube is very important, even if it's taped. So if it's taped, then you'd have to untape it every 8 hours and move it around. But so with something like this, it's nice because you can just move it back and forth. This is going to be a little irritating to your patient, so make sure you let them know. I need to move the tube over a little bit. If they've had it once, probably unless they just got intubated, it's not the first time they're going to be having it done. So, do you have anything to add on that, Sharon?
So a lot of times when you're documenting and doing your vent checks, you will actually say, you know, where you moved the tube from, if it was middle to left to right. Sometimes you'll also come across a patient that doesn't have really good teeth. So it can make it a challenge, and even if you just move it just a little bit, that's at least changing the pressure point on the face. Sometimes I've had to use tongue depressors to try to push the tongue down to get up and over to the other side.
Wow.
Sometimes, once again, back to the teeth, you'll be kind of stuck because maybe somebody's missing teeth here, and you can't literally get it up and out of the spot, but you know, you do the best you can. I will remember there was a time where we had a patient and people weren't moving that tube, and she had some tongue swelling and she ended up losing half of her tongue because that C-tube was pressed up against it. So
I've seen people with nasty sores on their lips and stuff. Yeah. It'll cause tissue death, you guys. So it's very serious because if you keep that pressure on it, then you're blocking off blood flow, and then it's going to necrose and die. That's why she lost her tongue. So very serious consequences. Some things that seem like little minuscule tasks are very important to the patient on the other end. So make sure we don't forget to do those.
So is the tongue never supposed to touch the tube? Or
No,
just
it
not
has to touch the tube,
to-
but it shouldn't be there for a prolonged amount of time.
Yeah, she had some swelling, and so the tongue was already kind of up, brushed against that tube, and so it was hard to move it, I guess, and it just kind of sat there and put the pressure against it, and nobody made the real effort. Because I know as a new RT, there's a lot of things you're kind of like, I don't know about this, I don't want to do it, but you know, you got to do it. It's in the end, you're helping the patient, leaving it there cutting into their face or their tongue or whatever is not helping them.
And if you're new and you don't have a seasoned RT, ask the nurse. They're not your enemy, you guys. Our nurses in very well-run ICUs, the nurses and the RTs are a team. They're not against each other. You guys should be working together. So,
What are the 4 things that can cause these again?
nasal cannulas on the ear, endotracheal tubes on the lips and the tongue, anywhere where the tube is touching, trachs, and BiPAP or CPAP masks.
So
And
anything.
bypass just on the nose, anything in the
No, they
face?
can get it anywhere if it's left on. Yeah, it's most commonly on the nose, but they can still get it in other places. You know, pressure ulcers are caused by anything that's sitting in the same place for an extended period of time. And an extended period of time is not like 3 weeks. It's, you know, a number of hours. So it starts. You'll see people, you take that mask off and you'll already see red. If you see red, then it's already started. So you should think about that. If you move something and that's red underneath, then it sat there too long.
When you see red, I mean, you're not gonna be able to just keep the mask off, like.
No, but for masks, we rotate masks. You can go from the pillows to the over the nose to the full face mask to the total face mask.
Okay, so
And,
That's cool.
yeah, and they also, don't forget from the presentations, have those little spongy things.
Oh,
yeah.
right.
It's a nasal pad or you'll
Yeah.
called like a gecko pad.
Okay.
And realize a lot of our patients aren't the healthy young person coming
Right.
in. They've already got maybe diabetes or some skin integrity issues to begin with. So it happens quickly because their skin is very fragile. You know, and if you see it, let the nurse know, document it. It doesn't mean you're a bad therapist. It's worse for you to just kind of say, well, maybe I'll just say I didn't see it. Let them know it's there. The nurse might have to take a picture of it because at least you're notifying her, you're trying to address it because there are things they can start to do to mitigate it.
Yeah, the patients, you know, if you haven't seen it, elderly patients, patients are on Coumadin or heparin, depending if they're in the hospital. So that's the blood thinners. So they're already bruised up and everything. And then a lot of patients, their skin is really, really thin. Have you guys seen elderly patients that have that real thin skin? So you have anything, tape or whatever, and you go to take it off, they very, very easily get sores. So some hospitals, I don't know how much the RTs will be involved in actually, but they actually do skin integrity assessments before you're putting BiPAP masks on and things like that. So it's very, very important part of what we're doing now. So, so that'll take care of it's the Hollister. So let's remove that. You also have to think about that if you're putting this on there too. Does the patient have skin that can even tolerate that? Other things you have to think about are mustaches and beards and all of that, because a lot of things can get in the way. Burn patients, if somebody's burnt and has all the skin that's off and it's all just where you're gonna tie it, how you're gonna tie the tube, how you're gonna secure it. So this is one that has this little spongy thing underneath and has, this is already pre-taped. I'm gonna show you how to tape it using kind of the same method, so you'll see how you would use these on either side. So using just regular old tape, some patients too that had really bad, thank you, burns, you can even, I've seen some people use tubing, like similar to O2 tubing, just because you had to have something to tie it around their neck and tie it around the tube and find a way to secure it, especially those patients with really bad facial burns, you'll have nothing to secure the tube to. And it's gonna be very painful. So you have to think about all that stuff. So if we're just using plain old tape, you're going to, and some people ask me after they get more comfortable with it if you have to use the tongue depressors or popsicle sticks. You do not. I'm just going to show you this way for right now until you are able to practice some. And so you're going to take the popsicle sticks and do this and fold it over like that. And then when we need it to, we'll be able to lift it back up, is the whole point. And then until you're good at this, you're going to have to visualize this would go underneath the patient's neck, and then I need this to be able to come up to this part. So how much tape do I need? See people with this much and this much. If you get too much, that's fine. You can tear some of it off. I'm gonna go back to this. And I need to go a little bit further.
And if you're in a hospital that doesn't have tongue depressors, You can be creative, you can use a clean yonker at one
Oh,
end.
yeah,
you
that's
can
right.
use the syringe off of the ET tube. The whole purpose is so you're able to slide that tape under the patient's neck, because otherwise, remember, they're in a bed, there's sheets, there's blankets, there's pillows, there could be vomit. You don't wanna be the one sliding your arm under their neck, and so you have the tongue depressor that'll come through so you can grab it on
It's very
the
easy to
other
grab. So I have this like this. So right now this is sticky side in the middle. So I'm also going to take a piece of tape and put over it so it won't stick to the patient's hair. Over here. The person doing the checkoff has to tape. You do not have to get it ready. So when you're ready to check off, which is not today, it'll be later, but I'm just telling you when you're ready. If somebody gets this ready for you, that's fine, but everybody has to tape as part of their checkoff, because you have to be able to secure an endotracheal tube if you need to, an old-fashioned way. And so if somebody's bagging, I mean, this is gonna sound crazy, but you could take a day to do this. As long as somebody can bag the patient, hold the tube, you're fine. You don't need to be in a rush, okay? This is not all about being fast. Sometimes it is, but I'm just saying. So this needs to be down around the neck, and it's gonna come up this way. So wherever my tube is, somebody's holding it this whole entire time. I'm gonna wanna make sure it's still at 21 at the teeth. And I'm gonna take this, and now I'm gonna, just so you guys see what I'm doing, I'm lifting up my tongue depressor, and I'm going like this, and I'm gonna get rid of this now, because I want all that to be sticky. And I'm gonna tear, and it may or may not tear for me. Does anybody have a pair of scissors?
In my bag, in the front pocket, there should be one in the bottom underneath my,
Goodies.
yeah.
You can never be too unprepared.
Nice.
Thank you.
You're welcome.
You guys, their scissors should be, Sharon, did the scissors, did they end up in a bin?
There's a scissors.
Oh, okay, I don't know if you guys put scissors in your bins.
Yes, we did.
Okay, good. That's okay, you can get them. So you'll need them. So you're gonna take this, and I'm gonna split it like this, and I'm gonna put one across the top like this. And in a perfect world, it's a little hard on the mannequins, but you need to think about a patient and think about the stuff we just talked about with pressure sores. There should be no tape on their lip, none whatsoever. So I'm gonna put that one piece down this way, and then without the pilot balloon getting stuck in it, I'm gonna take the other piece and I'm gonna loop it around. And I want you to notice I'm doing it all the way at the bottom, because I don't want the tape to move from where I put it. And don't tape the pilot balloon in it. And then at the end, leave your little dog tail, as we call it, so that you could undo it to retape later, okay? So we did that, and we're gonna tape that down. Now we're gonna do the other side. He does not wanna be on his ear. So I'm gonna go below the ear, like that. And now, I definitely have more than what I needed, but that's all right. We'll make it work.
You can always just cut it versus needing them.
Yeah, except I put too much on that part, but that's all right. I'm just gonna show you. I'm gonna just make that loose just so I can show you. Technically, this should be, you want the slit to be at this tube where it's at. You don't want the slit all the way down here, because then look, I have all this extra that's gonna be in the patient's mouth. So the slit should be at the tube. And I cut way too much tape. And we could cut it off about right there. So the first time I went this way, this time I'm going the other way. So that way, that time, now this time we're gonna sew. Now I'm gonna take this and I'm gonna go around the other side. And obviously if I hadn't cut so much, this would be flat and this would be, yeah,
You want it tight, but not too tight.
right.
You say like a fingers.
Yeah, underneath, just, yeah, usually can slide like that.
Okay.
So you're not cutting off the circulation back there too. Huh?
He asked if I could see, and I said I've done it.
Oh, yeah. She knows how to tape. Thanks, well. put my little dog ear at the end and then finish it off. So the idea would be if this was, of course, taut and not in the lip here, that it's not gonna come out. That's a secure tape job, okay? Then the last thing you'll do at the end, this kind of looks messy the way it is right now, especially because I messed up. But if you think about it, your patient's family is gonna be, so you've intubated them, you've put them on the vent, they're in the ICU now, they've got stabilized. Who's coming in? Family, friends, loved ones, crying, upset, likely that this was not expected. If it was, they're still not gonna be, they're still gonna be overwhelmed. So you need the patient to look their best as much as you can, even with an endotracheal tube in. We don't want this to be all jacked up. So you put an extra piece of tape over the top of it, and it makes just all that rough edges look very nice. That's the Mr. Rutherford touch.
And you don't wanna put it on the lip.
Right, so that's why I said this is,
Right.
because I had way too much, but yeah. Then a lot of the tape is easier to tear, and so if it's too wide on the lip, you can actually still tear some of it off and make it even narrower like you need it to be. That will make your patient look very nice and presentable for when the family comes in. It's bad enough they're having to deal with all this. We don't need them to look like crap on top of it. You do the best that you can, okay? Questions? Yes?
So this taping up is short term, right?
It depends on the patient, on their situation, on the hospital. Ideally, we are not going to tape every time, but sometimes we might have to because we can't use a Hollister or whatever. So then you would have to tape and retape every 8 hours. And you would need help to hold the tube while you're doing that again. You also can put the date and time on there so somebody knows when it was retaped last. Or some people are like, my signature? All right, so now you're going to, before anybody goes anywhere, just listen real quick. You're gonna practice today. We're gonna have a half an hour till the break. After the break, we'll have then an hour and a half. The first time you do this, it takes lots of time to practice to learn to intubate correctly.